Hi, everyone. Happy Wednesday. I'm Amy Hajari Case with the Pulmonary Fibrosis Foundation, and this is our next installment of our PFF Disease Education webinar series. I am so excited today that we have Dr. Anil Trindad from the Vanderbilt University to talk with us about lung transplantation, what to know, and how to prepare. Before we get started and I hand off to Anil, we're going to go over just a couple of housekeeping notes, particularly those who are new to the Zoom platform. We changed a few months ago from GoToWebinar, and so I'll share just a couple of tips and tricks for you before we get started. If you will go to your control panel, which should be at the bottom of your screen. You can go to the Q&A button if you have any questions, either technical questions about the webinar, and our staff who's listening in right now will help us to troubleshoot any of those and should get back to you. Or if you have questions about the content that you would like us to answer at the end of our session today, you can put in your Q&A box any questions that you might have, and we'll get to as many of those at the end of the talk as we can, but you can enter those anytime during the discussion today. Another feature that we have that is new is captioning. If you see the show captions button on the control panel, you can click on that, and then you can start to see captions. You can then click it again to hide it. If you don't see it immediately, you may have to click the three dot button and then hit more and then hit captions and show captions. There may be two ways you see that. Finally, if you would stay at the end of our session, we will give you a little form for feedback on our webinar and ideas you may have for the rest of our series. But without any further delay, I will get started. Let me introduce, I'm sorry. There is also one more thing. If you'll go to the chat button on your control panel, you will be able to download the slides from today's presentation there. So go ahead and hit those if you'd like to save them or review them later. But I would like to introduce my friend Anil. I'm so excited that you're here today. He is an associate professor and associate medical director for the lung transplantation program at Vanderbilt University in Nashville. Dr. Trindade trained at Duke University, residency at Johns Hopkins, his pulmonary and critical care fellowship training at the Harvard programs. And at Vanderbilt, he has worked tirelessly, I might say, because I refer to him not infrequently, and partner together to build the lung transplant program there, the clinical and translational research program, with a focus on improving the outcomes in our lung transplant recipients. So thank you so much for being here. I'm going to let you get started with your talk, and I'm so excited to hear this. Thanks.
Wonderful. Well, thank you so much, Dr. Case, and thank you to everybody at the Pulmonary Fibrosis Foundation for having me. This is really an honor and a pleasure. I enjoy teaching. I enjoy chatting with folks about lung transplantation. So hopefully this is an exciting chat for everyone. There's just a little bit of a medical disclaimer. So this is not supposed to take advice from your physicians, but this is just an educational session to get you thinking about lung transplantation and to get you started on that thought-provoking aspect. Because I think a lot of times when patients are diagnosed with pulmonary fibrosis or followed by their pulmonologist and then they're referred for transplantation, it may be a period of anywhere from 4 to 6 weeks or sometimes longer before they actually chat with the transplant specialist. And during that time, there may just be, it might be a time of anxiety. A lot of questions happen. Most patients, turn to Dr. Google and will, um, you know, search their questions, and some of that information may be correct and some of it may not be. And so, the whole point of today is to ask to answer some of those questions that you might have before you chat with your medical professional affiliated with the transplant program. There are going to be three portions of the talk today. So the first is just a basic primer of lung transplantation, really just addressing some of the basic topics. We'll then focus a little bit on how do you establish care at a lung transplant center, and what are the steps between when you're referred by your pulmonary fibrosis doctor to when you actually receive a lung transplantation. So hopefully it'll make that journey just a little bit less nebulous. And then there are a lot of the questions that we receive, especially patients who are really tuned in through the Pulmonary Fibrosis Foundation. You're clearly educated, you clearly do your homework. And so the questions that come up are, what can we do in that 4 to 6 week period by the time you're referred to a lung transplant center to the time you're actually seen to really optimize your candidacy? And so we'll chat a little bit about that. All right, so to chat about the basics of transplantation, so some of you might not have seen what lungs look like and what the connections are. So for lung transplantation, we're really removing the the native lung, so the lungs that you were born with, and sometimes we do single lung transplantations where one lung is removed and replaced with a donor lung. And sometimes we do what we call bilateral sequential, where one lung is replaced at a time. So the right or left lung might be taken out first and replaced with the donor lung, and then the same procedure done on right after on the other side, on the contralateral side. There are three connections that are made, and this might be a little bit difficult to see, but if you follow my pointer, so there's an airway connection, so air going from the native or the recipient trachea. So that connection generally happens at the main stem bronchus shown here. And then there has to be a connection for blood, right? Because the whole point of the lung is for gas exchange to occur. So uh, oxygen has to, the red blood cells in the bloodstream have to be oxygenated, and carbon dioxide has to be removed. So blood has to get to the lung, and that connection is through this purple vessel here, the pulmonary artery. And then blood has to leave the lung and enter the left side of the heart. And so there are two connections that are made, and these are the pulmonary veins, so the superior and the inferior pulmonary veins. So again, three main connections: airway, pulmonary artery, pulmonary vein. Whether you get one lung or two lungs really depends on your disease type, your age, et cetera, et cetera. I won't go into too many details regarding that unless there are questions. But suffice it to say, for most patients with pulmonary fibrosis, you can get either a single lung or a bilateral sequential, or what we call a double lung transplant. Majority of the time, because there'll be periods without blood flow, um, because you don't want blood going all over the place, you have to divert that blood flow from your heart. And so the majority of the cases are performed on some form of cardiopulmonary support. So that way you're oxygenating and ventilating during the actual procedure. Um, and so, your brain, your kidneys, all your vital organs will receive the nutrients that they need during the time of the transplant. All right, so I guess one of the basic questions to start off with is, why do we do lung transplantation? And so this is what I tell patients who see me in clinic. So we do lung transplantation for patients with advanced pulmonary disease. And we define that as a progressive lung disease, despite being on optimal medical therapy, and for patients whose expected survival in the next 2 years is less than 50%. And so there's really three components to that definition. So again, progressive disease, and then despite being on optimal medical therapy. So for patients with idiopathic pulmonary fibrosis, generally they're managed on an antifibrotic, so drugs like pirfenidone or Esbriet or nintedanib or Ofev. And they're progressing despite being on those optimal medical therapies. And then again, it's when your expected survival in the next 2 years is less than 50%. And I won't get too much into this, but there's some patients who are diagnosed with pulmonary fibrosis who may live for 6, 7, 8, years on optimal medical therapy, versus there are other folks who progress even within the first 1 or 2 years of diagnosis. And so you'll work with your pulmonologist to really decide when your expected survival is less than 2 years. And at that point is generally when you're referred for lung transplantation. So what do we achieve with lung transplantation? And it's really two things. So we do lung transplantation, one, mainly to improve survival. So again, these are patients who generally are expected to live less than 2 years without a transplant. And so the hope is to improve that overall survival. And then the other major goal with lung transplantation is to improve quality of life. And studies show that we're able to achieve both of these things. So this is a little bit of a busy slide, but it's one of my favorite slides showing the benefits of solid organ transplantation as a whole. So these are waitlist survivals both with and without a solid organ transplant. And this is data for many different organs, so kidney, liver, heart, and lung. This is a little bit of an older study. So this was published in 2015, and they looked at 25 years of patients who were added to the UNOS wait list. And they basically asked, what is the average survival or median survival without a transplant? So these are patients who were added to the wait list, but for whatever reason were not transplanted. And then what's the average survival after a transplant for patients who were transplanted? And if I draw your attention here to the lungs, you can see that median survival for those who were added to the wait list but were not transplanted was just a little bit over 2 years. And that's where we get that 2 year number from. Whereas for patients who were transplanted, average or median survival was a little over 5 years. Now, this was, again, back in 2015. So we say that the average benefit of lung transplantation is about 3 years. And again, that was back in 2015. Now, this slide is looking at median survival over different eras in lung transplantation. Lung transplantation, by the way, and I think we'll cover this a little bit later, is a relatively new field. So the first lung transplantation was done in 1963, but lung transplant as a field really didn't take off until the 1990s. So it's a relatively young field, being about 30 years. But if you divide survivals over these different eras, so from 1990 to 2000 versus the early 2000s versus the latter 2000s, you can see that median survival has improved over time. So if you look at 50% survival mark here in 1990, and this is conditional survival based upon if somebody survives the initial first year, then what's their overall survival? And you can see in the early times, it was about 5 years. But if you look at the red line, which is a more recent era, you can see that median survival is closer to 7 years, or 6.7 years to be exact. And so the question is, why has survival improved, and how have we allowed that to improve as a whole field, and what can we do in the future to further improve that median survival? And there's really a few things that has led to that survival over the last 20 years or so. So one, there's an improvement in surgical techniques. So thoracic surgeons are the people who perform the lung transplant procedure, and the technique for lung transplantation has evolved and hopefully will continue to evolve and improve. There's also improvements in donor procurement. So the act of removing the lungs from the donor and storing those lungs until they're implanted into the recipient. That period of time can be anywhere from 6 hours to even longer. And there are studies that are even ongoing here at Vanderbilt and around the world in terms of what is the proper temperature to store these donor lungs, for example. We used to think storing them on ice was the appropriate thing. Now we're learning that storing these lungs maybe at 10 degrees centigrade, which is about 53 degrees Fahrenheit, might actually be better. So there's work in that arena. We're trying to increase the size of the donor pool. We'll talk about a little bit later that there are not enough lungs to go around. And so there are measures to try to increase the number of lungs in that donor pool. So for example, utilizing lungs from donors who have hepatitis C, because hepatitis C is a very curable entity nowadays. There are also ways to support people who are on the wait list because some of our patients can get really sick while they're waiting for lungs. So using therapies like extracorporeal membrane oxygenation or ECMO so that patients can walk further and be better supported. There's also been improvements in candidate selection because not everybody who's referred for lung transplantation may actually benefit from lung transplantation, right? If you have multivessel coronary disease or poorly controlled diabetes, or you have, God forbid, cancers, those patients will just not benefit from lung transplantation. And in fact, we might harm you with lung transplantation. So that's something that has to be evaluated. And then there are folks like myself, so pulmonologists, who not only guide you through the lung transplantation process beforehand, before the surgery, but also guide you and take care of you after. And so there's things that have improved in the field, both in terms of how we treat and prevent infections versus how do we treat rejection. And so that there's a lot that's been ongoing over the last 20 to 30 years. So that deals with the survival aspect of lung transplantation. And I mentioned that one of the other major goals with lung transplantation is improving quality of life. And this is one of my favorite studies. This is from Jonathan Singer and colleagues at University of California at San Francisco that shows that quality of life after transplantation is remarkably improved. And so what he and his colleagues showed is he looked at baseline pre-transplant quality of life. This is looking at something called the short form 36, and this is looking at the physical components. So there's 12 questions looking at physical function. The solid line here is baseline quality of life pre-transplant. And then this dotted line shows what we call the minimal clinically important difference. So if you had an improvement from the solid line here after transplant, then that's enough to say that yes, transplantation was worth it. This axis here is time after transplant in years. So you can see that this is just a 6-month period before and after transplantation. And you can see that that difference before and after is more than threefold a minimally clinical important difference. So there's a huge difference just in that short period of time. And so we can show that quality of life is dramatically better with a lung transplantation. And more importantly, that difference is sustained for the period of the study, which was a 3-year period. So that's a dramatic slide showing the benefits of lung transplantation. And then this is looking at improvements in respiratory symptoms. And again, you can see that just within a very short period of time, there's a dramatic improvement in respiratory symptoms, which is not necessarily very surprising, right? We would hope that that's what we would achieve, but this is data showing that we can achieve that. So because we can show not only a benefit in survival, but also quality of life, it's no surprise that lung transplantation is a growing field, and there's really a period of market growth over the last 30 years, and I alluded to that. This slide shows really data until 2019, but we know that the growth is unparalleled and continues to happen. This is data from the International Society of Lung Transplantation. So this is international data. So as of 2017, there's more than 4,000 lung transplants being performed worldwide, and that's just reported, right? There's some centers that just don't report their data. We now think that there are more than 5,000 transplants performed per year. The majority of lung transplants that are performed are bilateral, but there's still not an insignificant amount of lung transplants performed that are single lungs. And there's better data to show that, especially for idiopathic pulmonary fibrosis, outcomes are the same whether you get one lung or whether you get two lungs. This slide's a little bit busy, so these are all patients that were added to the wait list in this purple line. And then, that's decreased because over time, patients are removed from the wait list, primarily because they're transplanted. So these are the numbers of patients that are transplanted off of the wait list. So they receive a donor lung. And then, unfortunately, there's some patients who die, and that's why they're removed from the wait list. And the most recent data suggests that about 15 to 20% of patients die on the wait list, meaning that there are just not enough lungs to go around. And so we as a field are trying to address that issue. So how do we make more lungs available to decrease the wait list mortality? And that's a big question that many folks in the field, especially people at my center, my colleagues are trying to address. Back in sort of the earlier days of lung transplantation, so the early 2000s, the leading indication for lung transplantation was COPD. And you can see that here in that purplish colored slide. But you can see that over the last 12 years, things have changed. So now the leading indication for lung transplantation are patients with interstitial lung disease. So, and the main type of interstitial lung disease is idiopathic pulmonary fibrosis. So again, that's leading cause. The number two cause is now patients with obstructive lung disease or COPD. You can see here in this pinkish line that the indication being cystic fibrosis is actually decreasing over time. And that's because in 2019, there was a wonder drug that was released called Trikafta. And so that drug really has helped a huge percentage of patients with cystic fibrosis. And then this gold color line are patients with pulmonary vascular disease, so idiopathic pulmonary hypertension being the main type of pulmonary vascular disease. And that's been studied due to improvements in medical management. All right. And then this is a busy slide, but the take-home point. So this is looking at lung allocation score, which is a way of prioritizing patients for need for transplantation. Another way of looking at it is how sick are patients when they're added to the wait list. And the higher the number, this score goes from 0 to 100. When you're closer to 100, that means that you're much sicker. And so this slide, sorry, I'm not sure it's actually showing up here. Okay, there it is. So you can see that patients on that red line here are the sickest. So that's if their allocation score is greater than 50. And you can see from 2006 until 2018, that percentage is almost doubled. So meaning that patients are older, they're sicker, they're getting to us in a much worse state. And so we as transplant physicians and surgeons are really having a more challenging time trying to support these patients through to transplantation. It makes our job a little bit more fun, but obviously when patients are referred to us in a sicker state, the expected survival is going to be a little bit decreased. So that's a take-home point, meaning early referral is better. The earlier that we can get you added to the wait list when you're less sick, the better overall. But sometimes, idiopathic pulmonary fibrosis or other forms of pulmonary fibrosis just kind of comes on right away in a very short period of time. And so despite everybody's best efforts, patients are just referred later. Having a little bit of technical difficulties here, so bear with me one moment, please. Um, for people at home, um, is the presentation still presenting? Is it still showing?
Hey, I can see it still. It hasn't moved. We're still on the patients awaiting lung transplantation, our sticker slide.
Okay.
See.
I'm not sure why I'm having an issue advancing here. All right, I'm just gonna. All right, did that help advance the slide?
Sure did.
Okay, great. All right, so just gonna go back. So the next part of the talk here is really designed to help answer the question. Okay, you've been told by your pulmonologist, your pulmonary fibrosis specialist, that you need a transplant, and the next few moments after that might be a big blur to most patients. Um, and so one question that comes up over and over again is, how do we get from that period of being told that we need a lung transplant to the next step where you're actually in my office or in one of my colleagues' office, we're actually talking about transplantation. So what are those next steps? So the first step is choosing a lung transplant center and being referred to one. There are about 70 lung transplant centers serving the adult population in the United States. And this is a slide showing some of them. This is a little bit of an older slide, so don't take this to heart. But you can see that there are some areas where there are a lot of lung transplant centers. So for uh, folks living in the New York area, there are currently 5 different lung transplant centers. Unfortunately, if you're in the Midwest or in the Pacific Northwest, your choices are a little fewer, right? So Seattle's one of the only hospitals and centers serving that large population. Your pulmonary fibrosis doctor might know folks, just like Dr. Case knows me, and she and I have a really great working relationship. So she might, refer a patient to me, or she might refer a patient, closer to her in her state, just based on the patient's insurance or logistics, whatever it might be. Your pulmonary fibrosis doctor probably knows a few people in the lung transplant world who they can refer you to. Some of the considerations might be, region, distance. You might not want to travel 500 miles. You might only want to travel, within 100 miles. Some of that might be reputation, right? So whose outcomes are better? Who's transplanting more patients, right? Because a transplant center that transplants 100 patients per year might just have a little bit more experience than a transplant center that's transplanting 10 patients per year. And then again, the relationship between your pulmonologist and that transplant center is really important, right? Because um, there has to be constant communication, constant feedback, and so that's helpful. So one thing that patients at home can resort to if they have to choose a lung transplant center or want to be more involved in that process is looking at the scientific registry for transplant recipients. So this is a data sharing component arm of the United Network for Organ Sharing, or UNOS, which is the governing body for lung transplantation. And so you can just type in WWSRTR, that's that blue link at the bottom here, and pull up this data for all the lung transplant centers that are available. Now it says here 74 lung transplant centers. I looked this morning, it's actually 75, but some of those are pediatric programs. So of the adult programs, it looks like there's 68 active programs. And so you can pull up, each program. There are 2 programs here listed. And so you can see how many transplants they did in the last year. So NYU, for example, did 67. You can look at survival on the wait list. And so the more bars that are highlighted, the better the survival or the better the outcome, whatever that outcome is. The other component you can look at is uh, the likelihood of getting a transplant faster, and then what's the 1 year survival. Now, all these metrics, take them with a grain of salt, right? Because um, programs might be more aggressive and might want to list sicker patients. Therefore, their survival on the wait list might be a little bit uh, lower compared to programs that are less aggressive and really only list patients that are healthier. So again, talking over reviewing this data with either a transplant pulmonologist or your referring pulmonologist might be a good thing if you have questions. Um, so let's say that you're referred. So let's say you're a patient of Dr. Case's. She refers you to Vanderbilt, and then you have an appointment with me. What does that look like? So generally, the initial visit is where you'll meet with a pulmonologist, and you might meet with several other individuals. What we do here at Vanderbilt is you'll have an hour-long visit. You'll also perhaps get some imaging studies, so generally a CT scan, and then you'll get functional studies, so pulmonary function testing, so spirometry and lung volume testing, and a measurement of what we call diffusion capacity, so what's the surface area for gas exchange. And then generally we do a 6-minute walk test to know how far can you exercise in a given period of time. The main objective is twofold. So one, for my benefit, it's to understand how sick are you as a patient, and what's your urgency for lung transplantation, right? Do we need to think about transplanting you, putting you on the wait list in the next 2 weeks, versus do you have a few months, and can we take our time? And then there's also, are there any obvious contraindications, or are there any barriers or things that might make transplantation potentially dangerous for you? So if we see you and you're frail, you've lost a ton of weight, or we know right off the bat that your diabetes is really poorly controlled, that's something that we can address hopefully quickly. And then the second objective is entirely for the patient's benefit, right? And that's where they learn center-specific details, right? Because not every center is entirely the same. Every center has their own protocols and timelines and metrics. And so while the majority of transplant centers function, you know, fairly similarly, I think 90% of what we do uh, is fairly similar from program to program. There is about 10% of criteria that might differ. And then that's really also the main opportunity for a patient to learn about the pros and cons of lung transplantation, right? Just like any other therapy, there are benefits and there are side effects. So, people on anti-fibrotic therapy, the benefit of being on that therapy is that it stabilizes lung function. But there can be lots of side effects, diarrhea, other GI side effects, skin issues, right? Sunlight insensitivity, et cetera, et cetera. So same thing with lung transplantation. As a therapy, I mentioned the benefits, so survival, improvement in survival, improvement in quality of life. But there are a lot of potential side effects and a lot of potential complications, to the point where we tell you that you're really trading in one set of problems for an entirely new set of problems. And then a phrase that you might hear is that transplantation is a roller coaster with lots of potential ups and downs. And so it's not necessarily a straightforward path. And so that's a time where you really hear all the data. And so we really want you to bring a caregiver, a loved one, a friend, a family member who can listen with you, because it can be a little bit of an overwhelming experience. You're probably only going to hear about, you know, 25 to 50% of the information that we're relaying. And we really want you to hear close to 100% if possible. So that's the initial visit. After the initial visit, there's a sort of triage process that can occur, right? So we might say, well, we tell Dr. Case and other pulmonologists to refer early, and oftentimes they hear us loud and clear. But sometimes we say, well, you're a little too well for transplantation, and so why don't you follow up with your pulmonologist, and then when you get a little bit sicker, you can be re-referred. Sometimes patients, despite everybody's best efforts, are referred a little bit too late, and they may potentially be too sick, and therefore um, lung transplantation might actually harm that individual and decrease their survival and decrease their quality of life. And so, unfortunately, we might have to say, listen, you're just not a candidate because, again, we can harm you with transplantation. Sometimes there's a middle ground where we say, well, you are potentially a candidate, you might benefit from transplantation, but there's things that need to be optimized. So you might need to control your diabetes a little bit better, or you might need your heart disease assessed a little bit more so in detail. And so once those things are done, then we can move forward. And then the the outcome that tends to happen more often than not, so more than 50% of the time, is that we need more information. So let's proceed to evaluation to make sure that all your other organs function adequately, um, to see if you can survive not only the surgery, which is obviously a big deal, but years of being on immunosuppression therapy. So what is the evaluation? And I think a lot of people are really intimidated by this. Um, but it's basically an opportunity for us to really look at you and assess you, and again, to make sure that all your organ systems are working well and that there's enough reserve for you to do well during the surgery and to do well many, many years. This is an example of the components of our evaluation process here at Vanderbilt. And this looks pretty similar at most centers. I don't want to bore you with the details here, but you can see that there's a few heart studies, right? So EKG, an echocardiogram, which is an ultrasound of the heart, a left heart catheterization, where we look to see what's the blood flow through your coronary vessels. We look at swallowing function, right? Because if in certain diseases that lead to scarring of the lungs, your esophagus might not work. And that might put you at high risk for aspirating, for stomach contents going into the lungs, which you can imagine is not a good thing after transplantation. We, of course, want to make sure that you're up to date on your cancer screening studies, right? Your mammogram, if you're of age, colonoscopy, all of these things, because we wouldn't want to transplant you only to find out 6 months later that you have colon cancer or some other entity that might be preventable. So that's the whole point of an evaluation. In some centers, they do this on an inpatient basis. A lot of centers do this in the ambulatory setting. So we prefer to do this in the outpatient setting. So patients come to our campus, they get a hotel room. The evaluation takes about 5 to 7 days. And that's a chance for you to also meet all the members of our team. So our social worker, our psychiatrist, our infectious disease folks who we work with very closely, meet with the surgeon who's actually doing the transplant procedure. And this is a chance for us to get to know you and your caregivers much more closely. After the evaluation is complete, um, uh, the selection committee, the lung transplant committee, will review your case. And we basically answer one question, and that is, will the patient benefit from lung transplantation? And sometimes the answer is yes, sometimes the answer is no. This is always a multidisciplinary process, right? So at Vanderbilt, there are about 40 or 50 people who join these weekly calls where a candidate is presented. And this is because this is actually one of my favorite conferences of the week. This is a chance for everybody to weigh in, right? So it's not just one person making this decision. And so that's important for patients to understand, right? Because sometimes patients will meet with me and they'll say, oh, I didn't get a good feeling from Dr. Trindade. He didn't like me. But it's just not me making that decision. There's 7 other pulmonologists here at Vanderbilt. There's 3 thoracic surgeons. There's again a whole team who's really looking at the interest of the patient to say, one, is this the right thing to do? Are we allocating this organ correctly? Right? We don't want to put an organ into somebody who's just not going to have a good outcome. So again, that's that selection process, and I'm happy to answer questions about that later on. There are 3 outcomes that can happen from the selection committee. One, somebody's deemed a candidate, meaning that we think transplant will benefit them. Sometimes the answer is no, meaning that we don't think transplantation will benefit that patient. And then there's a maybe, meaning that if they optimize X, Y, and Z, then they might be a candidate later on. Assuming that you are a candidate, then you're added to the wait list, and that's the opportunity for you to receive an offer for deceased donor organs. The one question that always comes up is, what's the average wait time on the wait list? And I think what's shocking to most people is that it's pretty short. So as a whole around the country, average wait time is 2.5 months. At Vanderbilt, not to toot our own horn, but our average wait list time is about 1 month. Um, what are the determinants of waitlist time? There's a lot that goes into this, but as a whole, there has to be compatibility between the recipient, the person receiving the lungs, and the donor who's providing those lungs. So there has to be compatibility in terms of size. Those lungs have to fit into the recipient. They can't be too big, they can't be too small. There has to be blood type compatibility. There's something called allosensitization. So um, if this is more so true in women, so if they've given birth or if they've received blood transfusions, they've received foreign tissue, and so their body will then recognize foreign tissue as being foreign and create antibodies. And so if you've had a prior transplant or lots of blood transfusions before, you might have lots of antibodies that might then potentially attack the donor lung. And so that might decrease the number of lungs that are available to you. And then there's something called the composite allocation score, which I'll review just a little bit later. But that takes into account several things. How sick are you, the recipient? And then what's the other main thing is what's your likelihood of survival 1 year after transplant? And so the whole point is to choose candidates who are sicker, but not so sick that they're going to die immediately after transplant. And again, this is a breakdown of that composite score. For the sake of time, I'm not going to go into this into too much detail. All right, and then I do want to leave time for questions, so I'll go through the next few slides fairly quickly. But one of the questions that we are asked is, in that period of time when pulmonologists refer their patients for transplantation, so again, it can be a period of 4 to 6 to sometimes longer, 4 to 6 weeks. What can that patient do to optimize their candidacy? How can they be a better patient and be healthier so that their chances of doing well with a transplantation is maximized? So there are a few things. So this is a slide. It's a little complex, but this is looking at 6-minute walk distance. So a lot of you might be familiar with one of the things that we do is we walk patients for 6 minutes and we look at how long they can walk. And generally, patients who can walk further in that 6-minute period do better. And that's true pre-transplantation and that's true post-transplantation. This is a study from the Duke group. This is now a little bit of an older study, but you can see that for patients who can walk further, so that's in this dark line here, that their life expectancy, and this is true 5 years after transplant, is much greater than for patients who can walk less. And so you can see for patients who can walk over 1,000 feet, their expected median survival is about 5.8 years. For patients who can walk less than 450 feet pre-transplantation, their survival is only 4.1 years after transplantation. So walk, right? We mandate here at Vanderbilt that candidates be enrolled in a physical therapy program we call pulmonary rehabilitation. So talk to your doctor about being enrolled in pulmonary rehab and then walk at home, right? So just practice walking. Um, what else can you do? So body mass and nutrition really, really matter. This is, again, a little bit of a complicated slide, but I want you to focus to the left-hand side here. This is looking at body mass index. And so you can see that there's a sweet spot in terms of risk of death. So you want your risk to be as low as possible. And this is kind of a U-shaped curve here. So if your body mass is really low, your risk of death is actually going to be higher. And if your body mass is really high, so above 35 or 40, again, your risk of death increases. So there's a sweet spot right around 25 to 30. So if you're overweight, then we really encourage you to lose weight. And if you're severely underweight, then we encourage you to improve your nutrition. Um, some of patients who are followed, some of these patients might still be smoking, they might be drinking, they might be using drugs. um, and most centers have a policy where you have to be abstinent from what I call the vices. So here at Vanderbilt, and I'm not going to speak for every center, but I'll speak for Vanderbilt, we say that you have to be nicotine free for a period of 3 to 6 months. You also have to abstain from alcohol, just because the liver metabolizes a lot of the post-transplant drugs that you're going to be on, the anti-rejection drugs. And so you can't be drinking and be on those medications. And then in the state of Tennessee, marijuana and other recreational drugs are illegal. And so we abide by our state laws. And so you can't be using those substances. Um, Most centers require caregiver support, right? And that's a little bit of a no-brainer because after transplantation, our patients are debilitated, um, and they're going to have scars, they're going to be weak, they're going to be in pain, and so they need people to support them through the next few months after transplantation. The Each program might have different requirements in terms of the number of caregivers and who a caregiver can be. Here at Vanderbilt, we require two caregivers, so a primary caregiver and then a backup. These people cannot be paid, right? Because once the money runs out, they're gone. There's no incentive for them to stay. The primary caregiver cannot smoke, right? Because then they're exposing the patient to tobacco, smoke, and other types of fumes, which is not good for the newly transplanted lung. The caregiver also has to be able to drive, and then they have to be physically able-bodied, right? Because if you're the patient, you're weak, you can't get to the bathroom at 2 o'clock in the morning by yourself. You need somebody who can physically support you. I think one of the biggest tips for caregivers and for the patient is the ability to learn how to delegate tasks, right? Because your focus as a patient and as a caregiver is on being the healthiest that you can be. And oftentimes you just don't have time to go grocery shopping or prep meals or pay your bills, especially if you have to drive to your transplant center, which might be 2 or 3 hours away. And so the successful patients learn to delegate. And so there are oftentimes lots of patients in your life as a patient who want to help you, they just don't know how. And so you telling them, hey, on Tuesday, I'm going to my transplant center, and therefore I'm going to be busy, so I can't mow the lawn. And it'd be great to have a hot meal waiting in my oven when I get home. So if you're able to delegate those tasks, again, there are lots of people, neighbors, churchgoers, whoever, who probably want to help you out. And so learning how to do that is really effective. This is a time also where you should organize important life documents, right? If you don't have a living will, if you don't have a legal will, those are important documents that you might want to have because you never know what might happen, right? During the period of when you're in the hospital during a transplantation, that's not a time to focus on paying the bills. So you want to have proxies um, who can do that all for you. Oftentimes, some of our patients are may still hold a job. And so the goal might be to go back to that job after transplantation, but there may be a period of 6 months where you can't go to work. So really, uh, detune, transition off, even if it's temporary. And so those are things that you want to focus on prior to meeting your transplant pulmonologist and team. Um, During that period where you're waiting to be seen by the transplant team, take care of all your other life health, right? If you need a mammogram, get that done. Same with your pap smears and colonoscopies. Now, you might be too sick to undergo conscious sedation, um, that twilight zone where you're asleep. So talk to your doctors. But if you're healthy enough and can get it done, certainly do those things. If you haven't been to a dermatologist, get that done. Get your teeth fixed. Get your hearing aids in place, right? Because one of the most important things during that period, right, is to um, be receptive to lots of different information. And if you can't hear that, that is a huge impediment. And so please get those hearing aids fixed. And then organize your life, especially your medical health. Make sure your medications are all in order and listed so you can hand that off easily. Same with your allergies. Your medical records should be sent to your transplant center. And if you have, imaging at one center, uh, if you have an extensive cardiac history, we want to know all and have all those records available. So make sure that's sent. Same thing's true with, again, imaging and any biopsy information. I'm sure lots of you have questions, write them down. Because when you're in front of your doctors, right, Dr. Case, myself, um, were so stunning that you might be left speechless. And so having those questions written down so you can remember to ask them right when you're in front of your doctor is really important. I think that really encourages a relationship of dialogue too. As a healthcare professional, I want my patients and their caregivers to be engaged and to really ask those burning questions because that shows that you're going to be responsible for that new set of lungs. And then one of the most important things, and this is true at any stage of life, is maintaining your sanity. And that's especially true if you've been told that you might potentially need a lung transplantation. So do the things that make you happy, do the things that keep you calm. Have your friend network, your life network, because these are the people that are going to get you by. If you're a nerve of balls, or I'm sorry, a ball of nerves, you're not going to be a good patient. So do the things that bring you peace. So I'm going to end there. Hopefully this was helpful. I know there are lots of questions, so I'm going to hopefully answer most of them over the next 10 minutes.
Thank you so much. That was really great. Just a whirlwind tour. But we do have lots of questions. I'll be honest with you. You answered. I think our audience today is so highly engaged. I think they may have been a step ahead of where you were, and so some of these questions are coming in, and you answered them very nicely. Just as their heads were going there, you went there too. But I am gonna try to first, before we go back over and retread anything, ask some of the questions that I think maybe we didn't quite get to, or maybe not in a lot of depth. So, um, I do, maybe let me ask which I think is kind of a quick one here, about the average time to expect for recovery after a transplant procedure. And when do people's kind of normal feeling of strength and stamina, get back to where they were?
Yeah, that's a great question. So Everybody's a little bit different, but on average, and these numbers are true more so at Vanderbilt, but they're probably reflective of most major centers. So after the actual surgery, the average ICU length of stay, so the number of days that you're going to be in the ICU, tends to be around a week. So it's 9 days here at Vanderbilt. The average hospitalization is close to 3 weeks. Um, and then we say that the average really recovery period is close to 3 months. Um, we actually mandate that if you get transplanted here at Vanderbilt, that you remain in the Nashville area for a 3-month period after transplantation, and a lot of that is so that you can get um, really aggressive physical therapy at one of our outpatient facilities. And so most other centers have a similar policy, and that's for your benefit because, again, most people are fairly debilitated going into transplant, and so we want them to really get a leg up in terms of their recovery period.
Great, thank you. We have another, had a few questions about requirements for vaccines and what is recommended um, uh, for prior to transplant. Obviously, immunosuppression afterwards puts people at risk. So, things that are recommended to try and prevent some of those complications. And do those differ between centers?
Yes. So great question. So lung transplantation is one of the most unnatural things in the world, if you think about it, right? We're taking your longer lungs out. We're giving you a foreign lung, and therefore your body's going to recognize that as being foreign. It's going to attack it. We call that rejection. So you're going to be on lifelong immunosuppression medications. These are toxic therapies. They're important, but they're toxic. And one of the main side effects, one of the main causes of death within the first year is infection. So you're going to be at high risk for infection. So we strongly advocate for our patients to be vaccinated even before they are exposed to immunosuppressive therapy, because that's when you can develop the best response to vaccines. So we ask our patients to uh, uh, receive all the CDC recommended vaccines, and you can go on the CDC website and look up the list of those vaccines. But it's things like vaccines against pneumonia, vaccines for influenza, COVID, RSV is a new bug that, well, it's not a new bug, but there's a newer vaccine against that. So all of these things are really, really important, and we highly encourage that. Now, there's some centers that mandate these vaccines. That's how important it is to your health and recovery post-transplantation. Because of state laws, we as a center cannot mandate that. Um, but if somebody is unwilling to get any of the vaccines, then that suggests that they may not be willing to undergo and adhere to some of the recommendations that we have after transplantation. And so that would be a serious concern. So again, we mandate that because we know as medical professionals that they're important to your health and recovery. So again, that's why that mandate's there, or that way that recommendation is there.
Very good, thank you. Would you mind, are you okay to go maybe 1 or 2 minutes over, a couple of minutes over? We have some great questions I want to get to, at least 1 or 2 more here. Would you mind advancing the slide? Just to make sure we thank our sponsors today before people leave. But I have a lot of questions about age. And this comes up a lot, and you referred to, relative criteria and things like that. But can you maybe comment a little bit more about age and whether there is an absolute cutoff or more of a relative, how people are doing kind of aspect to that?
Absolutely. So when we look at age, we try to think about what we call physiologic age. So how are your organs functioning, right? Because we know that we were probably in the primes of our lives in our 20s and 30s. And by the time you hit your 60s, 70s, and 80s, yeah, we're not doing that well, right? I'm in my mid 40s, and I certainly feel that I don't feel like I'm 20. Um, But we all know that there are some 50 and 60-year-olds who look like they're 85. And there's some 70-year-olds who look like they're, barely a day over 55. And so the focus really is on physiologic age. There are some centers who have an absolute chronologic age cutoff. Um, it- and there are other centers like Vanderbilt who really try to think more about physiologic age. And so, last year we've transplanted 3 people who were 76 years old. Um, I evaluated somebody for transplant at age 79. Um, now the thing is with age comes comorbidities, right? We all know that as we get older, we get high blood pressure and diabetes and cholesterol issues. So with age comes organ dysfunction. And so that's really the crux of the evaluation process is looking and trying to assess organ age for all your other organs. So how well is your heart functioning? How well are your kidneys functioning? And so that's what we're trying to look at. So it may seem that I'm trying to be vague a little bit, but again, it's hard to pinpoint physiologic age until we do the evaluation.
That's a great answer. And it is complicated, but that's why that thorough evaluation is so important, and all the different inputs from the transplant team are valuable as well. I'm gonna get in one more. I know people have busy lives, and I thank you for all your time. But maybe let's get in one more great question about people who go through transplant and have to take a break from work or unable to work due to the severity of illness, and while they're getting their transplant and recovering, do patients who are of working age or want to go back to work, are they able to after a transplant?
Absolutely. So, some of our diseases, including pulmonary fibrosis, tends to affect people who are of more advanced age. So we see a lot of retirees. But for patients who are of working age, um, the statistic is, I believe, around 25 to 33% of those patients go back to work. Now, I think that number can be higher. Um, I think some of that number is a little bit lower because after transplant, some patients say, "Hey, heck, I'm retired. I'm getting an income stream, so I don't want to go back to work." But for those people who want to, the answer is yes. For that is possible. Now, if you are working in the emergency department, let's say you're a nurse and you're coming across really sick people, that's probably not the ideal setting for you to go back, right? Because you're going to be exposed and you might get sick. And the whole point after transplantation, our main focus is on trying to prevent infections. But if you're able to reconfigure your work so that you're not exposed to sick people, then absolutely that's something that that we want for you, right? That's the whole point of transplantation, so that you can go back to your life close to how it was before you were sick with your advanced lung disease.
That's a great answer. Thank you so much. This discussion, your talk was so incredibly informative. I think our community as I told you earlier, is very hungry for this information, and your experience is just invaluable. I value you as a colleague, and but thank you so much for being here today. Thank you everybody for attending our webinar. We have some really exciting things. I know it's still the height of summer, but as we move into the fall, we've got more webinars coming. We have another watch party for our next summit video coming up soon. We have Pulmonary Fibrosis Awareness Month that'll happen in September. So much more to come the rest of the latter half of the year. And I hope to see you all there for those activities. Dr. Trindade, thank you again for being here today. It's just my pleasure to hear you and have you here. And thank you, everybody. Have a great rest of your day.
Take care.